Hi, this is the lecture on chapter 27, which is disorders of circulation within the central nervous system. All right, so just an overview of the chapter. I'm hoping we all remember that the brain and the spinal cord are the major components of the central nervous system. Obviously, the brain and the spinal cord, the nervous system in general, is responsible for detecting, transmitting, analyzing sensory information, and then generating signals, essentially out to the autonomic and the motor pathways that will control visceral, right? Control the organs, control endocrine functions, control glands in terms of what hormones they secrete, coordination, movement. All of these are part of the nervous system, central nervous system functions. Obviously, central nervous system requires lots and lots of oxygen. And so they are really dependent, or the central nervous system is really dependent on receiving constant perfusion. We'll also talk a little bit about the blood-brain barrier, which is essentially sort of this additional amount of protection to basically keep things from getting into the brain. Okay, so major disorders we'll talk about is transient ischemic attack, or TIA, which essentially is sort of a brief appearance of symptoms that resembles a stroke, but it's transient, goes away, no permanent damage. We'll talk about stroke, sometimes called a brain attack. This is more permanent. There is permanent damage that's incurred, and basically you can have disruption of speech, motor, communication, and also cognitive deficits depending on where the stroke is. Subdural and spinal cord hemorrhages, we'll talk about those as well. Okay, so some concepts related to disorders of the circulation within the CNS. It says that basically they revolve around lack of oxygen, right, and also increased pressure within the skull. So those are kind of the two problems that we're going to talk about. We talked about lack of oxygen and ischemia before. Essentially, ischemia can occur due to obstructed blood vessels and just a drop in blood flow to the brain. In terms of increased pressure within the skull, that can be caused from a hematoma, which is just basically bleeding into the tissue, bleeding outside of the blood vessels. Can be caused by excessive production of cerebral spinal fluid. There's various reasons why that might occur. And blockage of a duct that might essentially lead to a buildup of cerebral spinal fluid. And so if we look at our little diagram here of concepts related to disorders of circulation, you can see here again, perfusion is in the center because that's what we're talking about in terms of blood flow to the brain. And if that is compromised in some way, it basically can lead to these things that are kind of on the outside here. In terms of some kind of changes in perfusion, right? So trauma can lead to things like a subdural hematoma, tissue compression, things like that. If we focus on sensory perception and cognition, you can have visual disturbances that could be due to a stroke or something like that, right? Cognitive deficits, like I mentioned before with stroke. If you think about intracranial regulation, again, sort of regulating that amount of pressure that's there, you can end up with increased pressure caused by trauma, or that itself can cause trauma. If we're going to focus on oxygenation, then we can talk about ischemia, which then can lead to cell death, right? And thus to cognitive deficits and things like that. Okay, so this is, and we're not going to go through the entire vascular supply of the brain and the spinal cord by no means, just a really quick review of really, really major blood vessels. Okay, so just to kind of put some things in perspective, right? So the brain says it's 2.5% of total body mass, right? But receives 15% of cardiac output, okay? White matter, which is 60% of the brain mass, uses about 6% of cerebral oxygen. Gray matter, right, uses 94% of cerebral oxygen. So gray matter is where you have all your cell bodies of your neurons. White matter basically is the axons, right? So those are pathways where axons are extending somewhere else. So most of the oxygen is used up by the gray matter in the brain, okay? In terms of cerebral circulation, some major arteries, right and left internal carotid arteries, and the right and left vertebral arteries. Let's look at a picture here. So you can see these vertebral arteries right here and here, right? and then the carotid arteries here, right? And here, okay? So these are in your neck, major arteries in your neck. Obviously that are then right there essentially, I mean, here's the heart, right? Branching right off the heart and going straight up into the brain to supply the brain. So if you have a blockage in a carotid artery, major problem, and is going to obviously decrease blood flow to the brain. If you talk about, this is showing you, so it says cerebral sinuses viewed from the right side of the brain. So you can see sinuses and then all of these sinuses draining into that jugular vein coming down. Okay, again, if you have problems with the venule system, the veins, right, you can then end up with increased carbon dioxide and levels in the brain, and it's going to also lead to problems. Okay, so not only does the brain receive blood supply, right, and have blood vessels running through it like we just saw, and there are many other ones that I didn't show you, but there is also cerebral spinal fluid, or CSF, which will bathe the brain and supply brain tissue with nutrients and things that it needs. And so this is a totally different system. Okay, so the cerebral spinal fluid is produced in something called the choroid plexi of the ventricles, right? So again, I mean, I think I have a little picture to show you. Yeah, I'll show you a picture in a second. But, the ventricles are essentially these openings where the cerebral spinal fluid is housed. And then there's a whole system, a ventricular system that flows through the brain, okay? It says it flows through the subarachnoid space surrounding the brain and the spinal cord. So remember, your brain is covered with something called meninges, right? And there are 3 different layers. And so the cerebral spinal fluid flows between those layers. And at it really acts as sort of a shock absorber there. Okay. And then it gets resorbed into the venous dural sinuses. We just kind of saw some of those sinuses before in that last picture via the arachnoid villi. And so if there is a blockage, right, here with these arachnoid villi, and it can't be resorbed or sort of drained into the dural sinuses, you can end up with hydrocephalus, right? So this is just, I have a little typo there, sorry. Excessive accumulation of CSF in the brain. Okay, and like I said, one of the reasons could be that it can't be resorbed, or it could be some other blockage of flow through these ventricles of the brain. Okay, and so, like I said, here's a picture. You can basically kind of follow the arrows to see how the cerebral spinal fluid kind of flows through here. If you look here, right, you can see this is the dura. Right, here's the subarachnoid space, and you can see it kind of flowing through those layers there. Okay, pointing out just some things here. Here's the 4th ventricle. This here, hopefully it's labeled. Well, that's really labeled here. But basically, this is the lateral ventricle, the 3rd ventricle, and all where you see this blue is all cerebral spinal fluid that's going to flow through and around the brain. Okay? All right, so I mentioned the blood-brain barriers, briefly. Let's talk a little bit about that. So it says a specialized endothelium present in brain capillaries, right? So remember when we talked about essentially the structure of blood vessels, particularly arteries and veins, right, and capillaries, they all have the innermost layer is made up of epithelial cells. And sort of this endothelial layer is specialized in the brain capillaries, okay? And so it allows some things to get through. However, there's really tight junctions between those endothelial cells, and not much can really get through. So a lot less can get through here than can in other blood vessels, okay? So substances that can cross are highly lipophilic substances, will cross directly. Water crosses by simple diffusion. Most nutrients can cross by facilitated diffusion, but there are many things that cannot get through. And again, this is, it's a lot harder for substances to get through this barrier than it is through just passing through normal blood vessels in the periphery. Okay, so if you look here, right, this is showing your endothelial cell, right? You can see the basement membrane. So again, it's the other side of the cell, that's away from the lumen of the blood vessel. You can also see in green here, you have these astrocytes, which are glial cells, which are supporting cells of the central nervous system. And they basically provide a sort of additional layer here and make this barrier a lot tighter, okay? And a lot harder for things to get through, okay? So this is kind of showing you here things getting through these endothelial cells. But like I said, because you have this sort of extra layer of astrocytes here, it's a lot harder for things to get through, okay? And for very good reason, right? The body needs to do all it can to protect the brain, and so if it was easier for things to get through, potentially, you know, you can have drugs and other substances, you know, affecting the brain, and it could be dangerous, right? And so this is sort of this protective mechanism to protect your overall, you know, sort of master, you know, the brain. Okay, so it says there are, you know, I showed you that picture there, and for the most part, almost, you know, most places or most parts of the brain are protected by the blood-brain barrier. However, there are some areas where it's not. So the subfornical organ and area posterior of the brainstem, so 2 areas of the brainstem, also part of the hypothalamus and the pituitary gland. And I'm going to show you a picture in a second, okay? Those 2 areas, you don't have the blood-brain barrier sort of protecting it, okay? And I think I kind of already told you about that in terms of the composition, right? I already showed you this, tight junctions between the cells. You have specific transport mechanisms for nutrient passage and electrocyte regulation. You have astrocytes and also these tanocytes, these specialized glial cells that help set up that blood-brain barrier. Okay, so this is just showing you an example here. I told you in this hypothalamus, essentially a pituitary region, you don't have protection of the blood-brain barrier. I mean, and if you guys remember this, maybe when you talked about, you know, endocrine system in anatomy and physiology, right? And we kind of we talked about this in the beginning of the semester in terms of like the hypothalamic pituitary adrenal axis, right? You have neurons in the hypothalamus that extend their axons straight down into the pituitary gland, right? And then the pituitary gland, and you also have, you know, things released from the hypothalamus into this portal system, right, of blood vessels that will go down to the pituitary, and then the pituitary will leave things or secrete things that will go into the entire bloodstream, okay? And so here, this is not protected by the blood-brain barrier. Okay, so we're going to talk a little bit about cerebral autoregulation, okay, and what that means. So it says it's a mechanism that maintains steady flow of blood to the brain and the spinal cord. Again, I mentioned in the beginning how important it is to have sufficient blood flow to the brain, right? The brain has a really high oxygen need and also a high glucose need, and therefore if blood flow is not maintained, it leads to deficits pretty quickly, okay? So it says it'll maintain this blood flow to the brain and the spinal cord despite wide fluctuations in arterial pressure. So it sort of has the ability, even though there might be fluctuations going on, to maintain that sort of appropriate blood flow to the brain. Okay, and so if you talk about cerebral blood flow and what it actually means, it's just the blood supplied to the brain in a given time. Again, it's important that that cerebral blood flow is maintained at the, you know, the rate or the proper level that it should be. Okay, and this is basically matched to metabolic needs. Okay, so arteries can respond to pH, to carbon dioxide, and to oxygen changes, and then will you know, alter based on that. So it says if you have an increase in blood pressure, then these cerebral capillaries will constrict, okay? Decrease in blood pressure, those capillaries will dilate. Again, this is kind of overall changes that will happen, and then you have modifications in the brain blood supply to compensate for it, okay? Again, to make sure that steady flow of blood is getting to the brain, okay? So that's what we kind of mean by this cerebral autoregulation. So this is kind of showing you that a graph of what I just told you, right? So that's closely matched to metabolic needs, showing you that if blood pressure changes, you can see the change in either dilation or constriction of those cerebral vessels, right? And also then sort of the corresponding change in cerebral blood flow. Okay. Now, these mechanisms can fail, right? So it says if there's a loss of match between oxygen supply and demand of the tissues, right? You can have these autoregulatory mechanisms fail, and you have to kind of do something to sort of to not allow that to happen, right? And so that's kind of what this is telling you here, right? And you've kind of probably heard of these things before. So it's to reduce the release of excitatory neurotransmitter by inducing sedation or rest. So if there is a a imbalance between oxygen supply and demand of tissues, right? That the autoregulatory mechanisms are not enough to compensate for this, then there may be other means necessary to basically try to lessen the needs or decrease the oxygen needs of the brain, right? Or the metabolic demands of the brain. So, you know, if you sustain an injury or something like that, as these autoregulatory mechanisms become off balance, and as you have a decrease or depletion of oxygen, excitatory neurotransmitters are going to be released, and that's going to lead to more cell death and other problems in the brain. But if you sort of induce or increase rest, maybe by giving a drug that will lead to sedation, that can sort of help reduce the metabolic needs and maybe give the brain a chance to kind of get this auto-regulation back in check. You may have heard of this before too. You can use hypothermia to reduce metabolic demands of the brain tissue after injury, again, so that there isn't such a high supply or high demand for oxygen, and thus it will meet the supply at that given time. Okay? And so you can also, so if we kind of, what also can happen here is you can have an increase in intracranial pressure, or that if we kind of talk about autoregulatory mechanisms in terms of oxygen and supply demand, you can also think about it in terms of intracranial pressure, right? That there's a certain pressure that needs to be maintained. And again, if there's an injury or illness or something like that that's going to throw that pressure off, the body will try to compensate for that, okay? And so if you think about what exerts, you know, pressure in the sort of inside the skull, right? It's brain tissue, it's blood, and it's also cerebrospinal fluid, right? And so any change in one of those can increase the pressure, okay? So there's this hypothesis called Monro-Kelly hypothesis, in that it basically says that there are compensatory mechanisms that will respond to changes in volume in one of these things, right? And so for instance, here's the example, right? So if, say, there was a cranial tumor in the cortex, right? So this would be an increase in brain tissue. The brain, or essentially, or the central nervous system, will offset it by reducing the volume of the other two. And that's called cerebral compliance. Okay, sorry, I'm back there. Just to continue here, this is called cerebral compliance, meaning, again, this sort of compensation. If there's an increase in brain tissue, then the body or the nervous system will decrease the amount of blood. I guess not really the nervous system, right? Think about the body as compensating by decreasing maybe the amount of blood volume that's there, right? Or the amount of CSF to basically keep that pressure where it needs to be. Okay, so again, the ability to accommodate changes in volume without a significant rise in intracranial pressure. Okay, a rise in intracranial pressure is going to be a problem if it rises too high, because then things start getting, brain tissue gets sort of pushed on, and you start to have changes in function. Okay, so where do you have, you know, when does this happen, right? So injured brain tissue, you can basically have edema that's caused by, for cytotoxic reasons, vasogenic edema, and also clearance of brain tissue swelling. So basically, you have all of these things that can lead to an increase in pressure, okay, in injured brain tissue. So I don't know that you need to know the specific different types here. We all know what edema is. Essentially, if you have an injury, you have injured brain tissue, it's going to lead to increased pressure. If we talk about hydrocephalus, right, you can have excessive accumulation of CSF in there. We talked about this. And then that will compress surrounding tissues. And then that can lead to tissue damage, right? Which then will, you know, make the problem even worse. So some causes of hydrocephalus, and we kind of mentioned this, I think, before, lesions that will obstruct flow of the CSF, right, through that ventricular system that I showed you before, and also problems with resorption. So I kind of mentioned both of these when we saw that picture of the ventricular system and the CSF flowing through, right? Remember, the CSF was in blue. This is actually showing a CT scan showing severe hydrocephalus in a 67-year-old man. So the ventricular system, like I just mentioned, is in blue, and you can see how it's severely dilated here, okay? So, and obviously you're going to squish on all this brain tissue, right? That is not what should be happening. It's basically decreases the space that's there. And so, you know, something's going to be, you're going to have a lot of damage to the brain tissue because of this. Okay. So if we talk, now we're going to next talk about ischemia, right? And hypoxia of the brain and the spinal cord. Okay. And we've had these terms before. So brain receives 15% of cardiac output. The brain itself uses 20% of the body's oxygen consumption. I already made this point before. We've made this point probably a couple times in class, that the brain has a super high demand for oxygen, okay? And again, needs adequate blood flow. If not, there's going to be an issue, okay? So it says cerebral blood flow is influenced by autoregulation. We talked about that before. Blood viscosity, cerebral vascular resistance, cerebral perfusion pressure, and then there's this equation, right, that basically says that cerebral blood flow is equal to the cerebral perfusion pressure divided by this vascular resistance. I'm not going to ask you guys to do any calculations or anything like that, but these things are all involved. Okay, what happens, right, in the central nervous system if you have ischemia and hypoxia, right? Essentially, you'll end up with mitochondrial dysfunction, and what happens in the mitochondria? That's where you're going to get ATP produced, right? And remember, cellular respiration and production of ATP in the mitochondria is dependent or requires oxygen. Again, if you don't have oxygen, leads to dysfunction, and then ultimately can lead to infarction and tissue death, okay, because again of the lack of oxygen. And what will happen is these anaerobic glycolytic pathways might be initiated, right? We talk about glycolysis, right? That happens outside the mitochondria, does not require oxygen. And you can get a little bit of ATP from there, but nowhere near what the brain needs to function. But essentially, you'll have these pathways initiated to sort of compensate. And so if you ever, I mean, these are only initiated when there's problems and when there's a deprivation of oxygen. Okay. What then kind of starts to happen from there, right? Again, energy deprivation because you're not making enough ATP, like I said, if you don't have oxygen. Because of it, you will lose ion homeostasis because like the sodium-potassium pump does not function properly because it requires a high amount of ATP to run that, okay? And so leads to changes in concentration of ions, okay? Therefore, these neurons are unable to maintain negative membrane potential. Okay, so they're unable to maintain their normal resting membrane potential, which is a problem. Sort of as a result of all this, what starts to happen, and I kind of mentioned this a little bit before, is that excitatory amino acids will be released into the extracellular space, released in amounts and where they shouldn't be released. Okay, so because that membrane is depolarizing, right, and becoming more positive than its normal resting membrane potential, again, all due to basically a lack of ATP, okay, you then have other voltage-gated ion channels that will open, and you'll have these excitatory amino acids released into the extracellular space. If glutamate, which is an excitatory neurotransmitter, right, accumulates outside of the cells, basically, it will further depolarize the neurons and eventually lead to apoptosis. So, you know, when you talk about injury or areas of the brain that are injured, you will a lot of times, or one of the signs of ischemia or hypoxia is basically the presence of glutamate or these excitatory amino acids in the extracellular space, kind of where they should not be. Again, will ultimately lead to apoptosis. If we kind of continue with this, if we're talking about ischemia and hypoxia caused by, you know, hemorrhage, what also starts to happen is you will have immune cells activated. Those immune cells that are activated will cause leakage of the blood-brain barrier. Then you'll have leukocytes that will enter the brain that shouldn't be there because of the leaky blood-brain barrier. You'll have more inflammation that happens in the brain because of that disrupted blood-brain barrier. You'll have increased release of reactive oxygen species and things like nitric oxide. These sort of extra pathways that aren't normally activated will become activated. You'll have mitochondrial dysfunction, like I said before, and apoptosis. So you can kind of see how all these things kind of, all work together to basically, lead to more and more death of cells and more problems. Okay, so now we're going to talk about specific, illnesses, right? Pathophysiological issues, right? Like a transient ischemic attack. That's the first one we're going to talk about here. And so these TIAs are temporary episodes of neurologic dysfunction. They are transient. There is no permanent damage that happens, okay? But you'll basically have a focal brain, spinal cord, or even retinal ischemia that will happen without acute infarction, right? So you won't have any, so I guess there'll be a blockage or a obstruction of blood flow. However, it's not for long enough or to a high enough degree to basically lead to deprivation or enough deprivation of oxygen, right, to lead to cell death, essentially, okay? But for that sort of quick amount of time, you may have some symptoms that are similar to stroke, but they happen really quickly and go away really quickly, okay? So that's what this is kind of saying here. Again, you have a clot blocking the blood supply to the brain. Could be a lot of times caused by atherosclerosis, right, or accumulation of plaque in the arteries. Okay, there are many modifiable risk factors. Again, if you experience a TIA, your doctor will probably, we'll look at these sort of non-modifiable risk factors, and that's one thing. However, there's probably many things that you as a patient, or you must tell the patient that they need to modify so that they don't then sustain a stroke next time, right? So some of the clinical manifestations, like I said, are similar to stroke. However, they are quick and they resolve themselves pretty quickly, right? So it can be really any of these things that are listed here. Okay, so again, diagnosis and treatment. So you have to make sure that some of those symptoms that we saw on that last slide aren't because of something else, like a seizure or an intracranial hemorrhage, for example, because some of those symptoms will mimic a TIA, right? So to be sure that it is a TIA, blood glucose, other blood tests are usually used, ECG to, again, make sure there is no evidence of some cardiac problem. You can use non-contrast CT, MRI, right, of the brain tissue, CT, to look at the vessels, right? Carotid Doppler to, again, make sure there is no plaque that's there, or anything that looks like perhaps, maybe it's going to be suspect to rupture or what have you. Again, leading to a stroke next time, okay? All right, so that brings us to stroke, right? So we'll talk about two different types, ischemic and hemorrhagic strokes, okay? So for stroke, we're talking about an interruption in blood supply to the region of to a region of the brain, or bleeding of a vessel resulting in brain tissue damage or infarction. So now you have obstruction, but you're also going to have a decrease in oxygen for a long enough time. That's then going to cause cell death. Okay. If we talk about the sort of percentage of strokes that are ischemic versus hemorrhagic, many more of them are ischemic. About 87%, and only about 13% are hemorrhagic. Okay, so if we talk about ischemic stroke in particular a little bit more, again, partial or complete occlusion of cerebral blood flow due to a thrombus or an embolus, right? Again, part of that plaque or something that breaks off and blocks a artery, okay? Causes atherosclerosis, we talked about before. Other cardiac disorders can cause this. I kind of already mentioned this, right? Can eventually fully occlude a vessel or may rupture to release these emboli. Again, these are all caused by, they're essentially, cardiac disorders, okay? If you think about, I showed you before, the carotid artery, right? Middle cerebral artery, the basilar artery, these are common arteries where you would have, where you see stroke, okay? So this is basically showing you here, right? One of these arteries in the brain where you have a blood clot that forms, maybe, right? Again, it could be due to a plaque, right? You can have basically have an emboli there, or you can have a thrombus, right? So this is basically just showing you a blood clot or a thrombus here that's blocking blood flow, okay? And you can see, depending on where it is, so here, this is going to be the brain area that is affected, okay? So it's where it's in blue, it says area of ischemia, because it's going to be whatever blood vessels then would be supplying that brain area. If it was over here, then it would be this brain area over here that is affected, okay? And again, depending on where or what part of the brain is affected, that's going to dictate what type of symptoms you may see. Okay, if we talk about hemorrhagic stroke, this is basically bleeding into the brain. The blood vessel bursts, okay? So if you talk about intracerebral, it bleeds into brain tissue. Intraventricular bleeds into the ventricle. Extracerebral will bleed into the membrane surrounding the brain. Remember those meninges that we talked about before. If we talk about a subarachnoid hemorrhage, this is bleeding that's above the pia mater and under the arachnoid. Some causes, again, a aneurysm, cerebral aneurysm, where you have this abnormal bulge along a blood vessel wall. We talked about aneurysm before. About 85% of hemorrhagic strokes are caused by a cerebral aneurysm. Also, some of these hemorrhagic strokes can be caused by malformations. Okay, so there's these, I'll show you a picture in a second. I think I have a picture of it, where you essentially have these malformations and these tangles of abnormally formed blood vessels. Yeah, I have it in the next slide here. All right, so here you can see that this blood vessel bursts and you basically have bleeding into the brain tissue here. Again, obviously going to lead to ischemia. And obviously you need to make sure you get this person to the emergency room pretty quickly. And so this is showing you this sort of, these malformations here, right? This sort of abnormal kind of bundle of blood vessels here, okay? Which can lead to hemorrhagic stroke. Okay, in terms of clinical manifestations, right? Sudden onset of focal neurologic deficit, which will persist for at least 24 hours due to reduction or inclusion of cerebral circulation or rupture of the blood vessels, right? Depending on what happens. But again, if you see any signs of stroke, it is important to get that person to the emergency room so that, you know, basically you can resolve it before further damage is done. Okay, I already said this, sort of other signs and symptoms are dependent on what specific area is affected. There is a table in your book, table 27.3, that shows sort of some specific signs and symptoms of ischemic stroke. For whatever reason, that's not in the PowerPoint, but I would take a look at that. If I was going to ask you questions on any of that, I would probably provide that table for you, but it's worth taking a look at. Okay, in terms of treatment for ischemic stroke, obviously you would want to restore blood flow, right, and reduce that area of infarction. And so there's something called the penumbra, which is essentially the tissue that's surrounding that infarction. So you want to try to salvage as much of that tissue surrounding where that clot is and that lack of blood flow to basically keep it healthy and from those cells to die. Supplemental oxygen, okay, all things like that. Antihypertensive therapy, again, if this is due to or the patient has high blood pressure, which does put you at increased risk for an ischemic stroke. Okay, aspirin, which is a slight blood thinner hypothermia, I told you before, is a way of decreasing the metabolic needs of the brain. Okay, if you talk about treatment of hemorrhagic stroke, surgery, okay, craniotomy with aneurysm clipping. I'll show you a picture in a second, but a craniotomy basically is just a surgical opening of the skull. There are other types of endovascular therapies that can be used. And so if we look here, this is an example of this cerebral aneurysm clipping where you basically are clipping and tying this off, okay, because this bulge may ultimately burst, right? Okay. This next part talks about subdural and spinal cord hemorrhage, okay? And so, again, what we were talking about before in terms of stroke, this is in the brain tissue, right? Again, blood vessels that are supplying that brain tissue with blood. There is either a decrease in blood flow or a block of blood flow due to an embolism or a thrombus in there, or that blood vessel can actually burst itself and you can have that hemorrhagic stroke. We talk about a subdural hematoma, right, or a hematoma. Basically, you have bleeding in these bridging veins between the dura mater and the arachnoid membrane. So this is, again, between the meninges, that outer covering of the brain. Usually, a subdural hematoma is caused by trauma, okay? So high-speed impact to the skull. Also, child abuse, or if you ever heard of shaken baby syndrome, that can cause a subdural hematoma as well. Sometimes they do happen spontaneously. So if you have an acute subdural hematoma, basically you have this bleeding that's identified immediately after the injury, and you will try to do everything you can to stop that bleeding, obviously. But if basically you have a chronic subdural hematoma, it will eventually lead to brain atrophy, right? And what does atrophy mean? A decrease in that brain tissue. Okay, and so this is showing you a brain scan of an adult with a subdural hematoma, okay? And you can see atrophy of the brain tissue there, okay? So the brain tissue should be going to the edge here. Okay, in terms of clinical manifestations, headache, right? Confusion, dizziness, nausea, vomiting, seizures, okay? Treatment is essentially surgery, okay? If you talk about hemorrhage of the spinal cord, it's pretty rare, not, more common that you see the subdural hematoma. But again, due to trauma, vascular malformation, and also bleeding disorders, you may see hemorrhage of the spinal cord. Again, it can be in kind of different compartments, right? So if you talk about intramedullary, this is bleeding in the white and the gray matter of the actual spinal cord, so the spinal cord tissue. You can also have bleeding in essentially kind of in the outer covering, right? So it says the subdural hemorrhage, just like we said, right? We talked about a subdural hematoma, same idea, but it's in the spinal cord. And then that would cause compression of the spinal cord and ultimately issues from there in spinal cord function. Okay, so it says sudden severe back pain with or without radiculopathy, so which is called a pinched nerve. Okay, so if you have this compression, right, event, it can basically push on the nerves that are extending out of the spinal cord. Okay, headache, neck stiffness, things like that. It says irreversible sensory loss below the level of the bleed, right? Because again, this is blocking transmission of sensory information coming in from the periphery up to the brain, essentially up the spinal cord and then to the brain. Surgical decompression is basically treatment. If you're talking about subdural, if you talk about subarachnoid, again, this is just a different layer of the meninges. Same thing, surgical. Resection, meaning you may be removing some of the tissue there, okay? You can also place a catheter in there. Focal radiation therapy can be used as well. All right, and that concludes this lecture.